Let's look at it another way. Mean change in body weight, right? And there's going to be standard deviations around that, you know, and we'll get into that in a few minutes. But just in terms of means, another way to think about it, there's a wide spectrum of weight gain. And here we're looking at short-term change. Standardized 10-week treatment. And I love this slide. I love this paper from David Allison because it really hammered home very early on. This is not a second-generation problem. This is a problem with individual molecules. And there are good and bad actors in the second-generation class and good and bad actors in the first-generation class. And we could go across therapeutic classes outside of psychiatry, and we can find a host of medications that cause weight gain and individual molecules within those so-called classes, you know, producing different amounts. So at the bad end of the spectrum, our friends olanzapine and clozapine, and our old friends chlorpromazine, thioridazine, mesarizidine. At the good end of the spectrum, new actors like aripiprazole, ziprasidone, but also our old friends haloperidol and flufenazine. So, you know, I think it's a really important take-home here if we're going to try to configure any sort of guidance that you make sure, as we've already done in some of the language, it's really not about second generation. It's about, you know, drugs with specific risk profiles. Okay. Now, the problem with that slide is I don't treat people for 10 weeks. I mean, Terry was advocating an important, you know, rescue, short-term rescue strategy. But for the most part, in Missouri Medicaid at least, I don't see people on 10 weeks of antipsychotics. They're on it for a rather long haul. So what we did was put together this slide where we pulled from separate either package inserts or development programs or big studies, you know, what was the profile of weight change, mean weight change, pounds on the right, kilos on the left, for different antipsychotics. So if you remember back to the slide right before, we were at 10 weeks, and the horse race is a little closer. Okay? It's when you let the horses run for a while that actually you can start to see this impressive separation. I think Terry was talking about the very rapid increase in weight that you could see with some drugs, but some drugs produce this increase and then they're done. You know, whatever they're doing to appetite or satiety has finished playing itself out. You hit your new equilibrium and you now achieve your new weight gain and you're there. Other drugs, you know, essentially olanzapine produces a ceiling effect. You know, you just can't gain weight faster than that. And if this is why the Lilly folks are now saying if you see 5 pounds or whatever in the short term, it means you're up against the ceiling and you might want to think about attenuating the trial because it's very likely to continue if you let it go. So walking you through ziprasidone, aripiprazole, one more point on this. Most of the data that's been reported in the literature, in the package inserts, in papers from companies, is last observation carried forward. Terry was talking about some of the downsides of available data to really get your hands around risk, and that's certainly true for weight gain, where LOCF was the traditional reporting method, meaning that if this guy, you know, was actually, in a particular study, a guy didn't make it 52 weeks, he made it 24. And he dropped out. His weight at 24 weeks was averaged into the 52-week endpoint. Okay, so that's last observation carried forward. And the FDA, Tom Lofgren and others, you know, are pretty sick of LOCF as a way of tracking adverse events. But most of these, so understand, most of these are LOCF lines. I'll point out the exception. Aripiprazole, ziprasidone, about 1 kilo mean at 52 weeks, LOCF. Risperidone, 2.3 kilos mean, LOCF. Quetiapine, 3.6 kilos mean, but it's not LCF. It's observed case. So if you actually made risperidone observed case, I'll bet you it would be almost identical, and I'll back up that speculation in just a second. Notice here haloperidol. So this slide's teaching a few lessons, which I'll hopefully prove to you in the subsequent slides. Here's haloperidol, which we thought was a low-risk weight gain medication. But this is from an old haloperidol first episode study. Okay? And that's a little message. Any of these drugs, when you put them into the first round of treatment, okay, will produce more weight gain than you see in the 10th round of treatment. Here's chlorpromazine, which we would expect to produce more weight gain. There's two lines for olanzapine. This line is pooling together 2.5 milligrams per day up to 17.5 milligrams per day. This is Bruce Kynan sort of pooling together their registration database. But Charlie Nemiroff had actually pulled out with a Lilly statistician. He said, no, let's break it down by individual dose groups. And he pulled out the 12.5 to 17.5 dose, which is the antipsychotic range from the trials. And that delivered about 12 kilos of mean or average weight gain over 52 weeks, LOCF. Okay? That means some people more, some people less, but 25 pounds, you know, in 52 weeks. That was an impressive signal. That got everybody's attention. Now, the problem with the slides I just showed you is they aren't head-to-head comparisons. Those were plucked from separate registration databases. So let's do some head-to-head comparisons for a reality check. This is the CAFE study. It was when, it's the Katie network, when Jeff Lieberman couldn't get Tom Insel to pay for, a first episode version of Katie. He went to AstraZeneca and got AstraZeneca to pay for a version of that. I want you to just look at this 52-week mean weight change bar. First of all, it sort of validates the 52-week mean we've been seeing for olanzapine, up around 12 kilos. But notice for quetiapine and risperidone, 2 points. One is they're almost identical, and you'll see that in the Katie study and in other trials, because when you do it apples and apples comparison, both observed case or both LOCF or mixed model, whatever, they really produce almost identical weight gain, despite everyone's perceptions based on the lawsuits. Okay? And notice also that this mean, this similar mean of 6 kilos is way more than you would expect, but it's because it's first episode or early exposure kind of sample. If we then looked at risperidone or quetiapine, as we will in a minute, in a more chronically treated sample, the numbers will be very similar again, but they'll be much lower. And there it is. So there's the Katie study. Now, phase 1 Katie, you've got, again, similar numbers for quetiapine and risperidone, but at under a half a pound per month of treatment, you're going to come out in a different place. Similar 2 pounds per month of treatment for olanzapine. Now, something funny came up in Katie, and that was a mean reduction in body weight with perfenazine or ziprasidone. And so, you know, that's worthy of some discussion here, because nothing I've shown you so far, nothing I could show you, would indicate that these drugs are weight loss products. So why is it that you're seeing mean reductions? And I think you have to remember that Katie was a chronically treated sample entering the study, and what was the dominant market product at the beginning of the Katie study? It was olanzapine. They had 40% market share. Okay, so, and we've seen in the subsequent analyses that most of the people, that more people entering Katie on a single agent were on olanzapine than on any other antipsychotic. So hypothesis, which we'll go on to test, hypothesis, maybe these are reductions because they're switching off of something else. And that, again, gets to a sort of possible recommendation angle we could play on. Maybe if you are in trouble and you can afford to switch, switching might give you a metabolic benefit. So we published the first sort of proof of concept, double-blind, randomized clinical trial where you take overweight, obese patients on olanzapine, you randomize them to stay on same or switch to aripiprazole. Okay? It could have been ziprasidone, it could have been haloperidol, but you lose weight on the lower risk arm and you continue to gain on the higher risk arm. But both in CAMP and in this study, and I'll go on to talk about this, they looked very carefully at what's the psychiatric risk of the switch, because we've alluded to the idea that switching carries some risk. The mean CGI scores in both groups was in the range of no change to minimal improvement. There just aren't a whole lot of crash and burns. Okay? And certainly the average experience is not a negative one in either one of these arms from a psychiatric standpoint. Here's Peter, this is an analysis we did with Peter Wyden where he took a group of people who were previously on haloperidol and switched them to ziprasidone, previously on risperidone, switched them to ziprasidone, and previously on olanzapine and switched them to ziprasidone. And it made the point that if you go from a low risk to a low risk drug, nothing much happens to your body weight. But if you go from particularly olanzapine, a higher risk, to a lower risk drug, you could actually see some impressive reductions in weight. Here, a 20-pound mean improvement. This is a neat paper from Bob Rosenhack, just making the point. I can't tell what side of the street Bob's on sometimes, but here he's making the point that the switching, you know, for all the concern that terrible things would happen to people psychiatrically when you switched, that taking the folks who were on olanzapine entering CATIE and then comparing the stayers versus the switchers, the people on risperidone comparing stayers versus switchers, or the people on quetiapine comparing stayers versus switchers, there was no significant difference for stayers versus switchers on any of these measures, with the sole from CATIE, with the sole exception in the olanzapine group, the stayers versus switchers had a highly significant change in their body weight. Okay, so Bob is putting some bookends on the concern from Susan Essick and colleagues, you know, in the CATIE post-hoc analysis. It is true, statistically speaking, that switchers experience a bump in the road. And there's more all-cause discontinuation in a switcher than there is in a stayer. But when we get into number needed to treat, and we actually look at how many people are we talking about, and what's the odds, and what's the average change in things like PANSS scores, etc., it's really not that big. So I think that there have been a little bit of partisan politics here, where some people sort of playing the fear factor card have suggested that switching has grave risks associated with it, and everybody should just stay on their high-priced product. But that's worthy of debate. So we just finished an NIMH-funded study in children. This was, you know, a very generous $6 million single-site R01, where we got to study antipsychotic naive children who were going to be randomized to start antipsychotic XYZ. I'm not a child psychiatrist, but I got to tell you, I was chairing Missouri Medicaid's drug board, and I saw this rising rate of antipsychotic prescription in kids. And it wasn't for schizophrenia, and there was no epidemic of childhood schizophrenia happening in Missouri. This was because child psychiatrists and pediatricians, in their wisdom, were deciding that antipsychotics were a good approach for disruptive behavior disorders. Okay? And full disclosure, I was not sympathetic. You know, I thought this sounded pretty crazy. So we set out to, you know, shoot a hole in the bottom of the boat by looking at what happened metabolically with some very careful measurements. This is DEXA. It's a dual energy X-ray absorptiometry. It's a body fat measure. We had MRs of the abdomen. We had hyperinsulinemic euglycemic clamps, very fancy measures. So this is the DEXA scans. And just to walk you through it for a minute, because to me, you know, staring at this for a long time really helped me. Antipsychotic naive children, half of them are on stimulants, half of them are not on stimulants. The stimulants made no difference, okay? No significant difference in the outcome. The risperidone and the aripiprazole had essentially identical results, okay? A little bit more variance in the risperidone group. These are box plots. So the black line is the median change in % body fat from baseline, 12 weeks. The outer edges of the box are the 75th and 25th % confidence interval, and the whiskers are 95% confidence intervals. And any dot that shows up outside is an outlier. Okay, so most of it's captured within the 95% confidence intervals. So notice, for risperidone and aripiprazole, actually some percentage of the patients lose weight, okay, lose body fat. Okay, we don't hear about them. What we hear about are the top of the whiskers, where, you know, Dr. Jones says, oh my God, I saw this kid who gained, you know, 25 pounds, 10% of their body fat went up, and but the median, the true median, is rather modest and very similar. And here I'm wearing my Medicaid hat. It's very similar for my under $100 per user per month drug versus my $400 per user per month drug at pediatric doses even. So that, I thought, was an important result. The olanzapine group was interesting. Of course, olanzapine won in the sense that virtually everybody increases body fat. The median is substantial, and you can get some people making some pretty significant changes, even over short-term time frames. I wanted to put something in about, Joe, you mentioned metformin. Okay, so we started seeing, actually we're writing up a paper now from Missouri Medicaid data, you know, what's with all this metformin that the psychiatrists are now writing? Not in diabetics, not in pre-diabetics, but as essentially an adjunct therapy to antipsychotics, either late to the party or at the beginning of the party as some sort of weight gain attenuation treatment. So I wanted to frame some context in the, just very quickly, in the, if the problem is already developed and you add metformin, the literature is not very impressive that it helps. If you are starting out with metformin at the same time as the antipsychotic, you can get a significant attenuation of the weight gain in a number of studies, not all, but it's not like it zeroes it out, it just attenuates it. I'm worried about the safety issue. I mean, I don't like the idea that psychiatrists are prescribing metformin. You know, my concern is that there's only one good large-scale study of metformin outside of diabetes, and that was the Diabetes Prevention Program, a huge public health effort where they took pre-diabetics, people with impaired fasting glucose or impaired glucose tolerance, and they randomized them to either get care as usual, metformin, or a therapeutic lifestyle intervention, basically diet and exercise. At the outset, there was a fourth arm. It was triglydzone, but triglydzone killed somebody in DPP, and it subsequently was found to have hepatic toxicity. It was pulled from the US market, and so it was out of the study.